Welcome to the Coast Podcast. I'm Emilie, a virtual assistant agency owner who left Amazon in 2019 to build my dream.
And I'm Whitney, a freelance writer and communications consultant who never felt at home in a cube farm.
We wanted to learn from people who paved their own ways like we did. So we created this podcast to talk to others who are brave enough to pick a different path. Creatives, entrepreneurs, people doing their careers and their lives their way.
Join us as we make new friends, get inspired, and show you beautiful paths less traveled.
Not every road leads to the coast, but the ones that do come with a great view.
Hello, everyone. Welcome back to the Coast. I'm Whitney Popa, and I own a communications consultancy in Edmonds, Washington.
And I'm Emilie Given. I own a VA agency in Linwood, Washington. And today we have Rachel Jalanivich. Wait, I should have asked you that.
Really good. That was really good.
Who is the owner and doctor of physical therapy behind Empowered Physical Therapy, mainly specializing in pelvic floor, right? Can you tell us how to say your name? That'd be great.
So my last name is Jalanivich. You were really close, though. It was really impressive.
Wait, my husband would know the itches. What origin is that?
It's Croatian. But according to my 23andMe, I am 0% Croatian. So my whole life is a lie.
Interesting. Okay.
So, yeah, 0% Croatian. Yeah. But so I'm the owner of Empowered Physical Therapy in Lake Stevens, Washington, and I specialize in pelvic floor. And apparently lots of people don't even know what that is.
Yeah, let's start there.
Yeah. So first of all, everyone has one, males, females, if you're assigned, any gender has a pelvic floor. We all have it. It's just this basket of muscles that connects from your pubic bone to your sit bones all the way to your tailbone. And it has different functions. It helps with sex and peeing and pooping and lymphatic movement and a little bit of structural support and some hip stability. So that is the pelvic floor. And when things go wrong in the pelvic floor, we get things like pelvic pain or pain with intercourse or constipation or UTIs or urinary urgency frequency, leaking, hip pain, low back pain, all those kind of unfun things that happen down in that area.
There's so much we could say about this.
Yes.
Yeah, basket of muscles is my new term.
Right? It's just kind of like a hammock.
Mm-hmm.
Yeah.
Oh, God. Like, what a metaphor. And also the fact that you're like the second or third person that I've encountered, maybe because I'm a mom now, where this is like a niche and it's a big, important one. The fact that you focus just on that area. And I would imagine, like you said, any gender, but like you have a lot of female clients, because I wouldn't think that men would necessarily, unless urged by a woman. I love to stereotype, especially the white male population, but like I can't imagine that you have a lot of men coming in on their own being like, I have issues with my hammock.
So I do specialize in women's care and or vulvar care, right? There are continuing education courses that I have not taken in penile care, and I don't have a penis. So frankly, I don't always know exactly when people have penile questions. I've worked with some men before on testicular issues and on like rectal issues, but I've never, I have been very consistent telling men that like, hey, look, I don't treat penile issues. Interestingly, those muscles are all very close together. So you typically have more than one issue. So if you're having penile issues, which frankly tend to happen with rectile and scrotal issues too, I feel like you're better served with somebody who has had that training.
I was trying not to laugh at the word penile over and over. Like, it's a weird word.
I heard vulval.
Vulvar?
Vulvar.
So, okay, before we started recording, I was like, Rachel.
This is going to get my teenage boy out really hard.
Yeah. Really hard.
You can't say words like that in my life.
I before we started recording, I was like, okay, so like I want to talk about how I know Rachel, but I don't want everybody to know that I have like a anyway. Like my stuff is falling out because I had a baby. Like, and I was so like I didn't want to talk about it, but now I'm realizing how actually important it is to talk about it because I felt really alone and like ashamed of talking about it, and I want to feel empowered physical therapy. So like, guys, this happens.
I knew that you would change your mind very quickly.
This happens all the time. And it's like, really, when I found out what was happening, because like my husband has this like really cute habit of like making me lift heavy things. And I'm like, fuck you. Like I'm a tiny woman and I'm strong, mostly emotionally, not very physically, but like I'm like, I can't help you lift this like 300-pound object. And like I kept doing it, and like I was carrying around EJ, who was 4 at the time when I figured all this out, like, and I'm like, something feels like not right, like it's like,
something feels like it's falling out.
And I'm like, this is weird. So I went to my OB/GYN. I guess she's a GYN now that I'm not pregnant, but she's like, you have a prolapse. And I'm like, okay, like what the fuck does that mean? Like, and I just got really angry. Not that it happened, but like about that we as women don't know or aren't told or aren't like prepared for this. It's not talked about in pop culture. It's not talked about. Our mom friends don't tell us like, hey, your shit can fall out. Like, what the hell?
Junk, and shit.
Not actual shit. Like, but that can happen. That doesn't happen to me. I just want to clarify.
But the junk part of the shit,
Yeah. So the prevalence of prolapse is like 40% of women. It's a lot. It's very common and it's not normal. And it can worsen by how you're managing pressure. So prolapse is a pressure management issue. So you need pressure in your body. You need pressure for your posture. You need pressure to move heavy things. You need pressure to breathe. Pressure is super important. But when we mismanage pressure and we kind of bear down and put extra pressure down on the weakened pelvic floor ligaments or pelvic floor or ligaments that are supporting your organs, and those tissues, and we're putting pressure downwards, especially when, we can get into hormones here, we can get into lots of things, but especially when you're in a postpartum state, your estrogen has decreased, especially if you're breastfeeding still, and you've just pushed a baby out, and that's a lot of pressure to push a baby out.
Or cut a baby out. You said in my case, like a lot of times in C-sections, like those muscles are completely like cut and you're...
Yeah. It depends on the cesarean approach. It depends on if it was a planned cesarean. It depends on if you were pushing and then it was all of a sudden a surprise cesarean, because then you have both traumas. You have pushing trauma and then you have surgical, like you have a massive abdominal surgical trauma from a cesarean. And to think that that wouldn't cause pressure management issues when they've literally cut the muscles that are part of your trunk and your pressure management system, that's ridiculous. So yes, cesareans, I see a lot of cesarean, even if it was planned. There's just a lot of issues that come after those too. But prolapses are prevalent. And then there's such this culture, and I don't know where it's coming from, but there's this culture that like, you should just be up and walking and going on walks, pushing your stroller 7 days postpartum. Like, what is that? Because you should be resting for like at least 2 weeks. You should be like chilling in your bed for 5 days, chilling around your bedroom for the next 5 days. That's 10 days. You didn't even leave your bedroom. And then the next 5 days, you should just be like chilling around the house. That's 2 weeks you didn't leave your house.
Those people in the hospital made me like walk around my room like day 3. I'm like, yo, I'm dying. Like,
I walked, that first day, but I also delivered vaginally. And in China, you got to go to China because it's 2 months that they don't even let you shower.
They don't let you do anything. Yeah.
And you eat soup.
I like soup.
And people bring you food.
Mm-hmm.
It's like a weird cultural thing in America. And I'm wondering, I haven't looked up the prevalence rates in America versus China, but I'm curious if the prolapse rates are higher here because we're just frankly not resting enough postpartum.
Interesting. That's so. And like something the one thing that you do hear, right, when you have a baby, like when you have a baby, you're gonna like pee when you sneeze, right? Like I heard that before, maybe from like my sister or whatever. She said once, she's like, yeah, in the trampoline park, like if you get an invite to a birthday party, she's like, fuck you. Like, I don't want to go to your trampoline park. Literally.
All the moms sit on the sides or they wear a panty liner and black yoga pants. Forget the colorful ones. Like they want the black ones because they think they're gonna probably gonna leak. And it's such a misconception that is just your life postpartum. It's not. It's a risk factor. Okay, we can acknowledge that there's a risk factor involved with, you know, being postpartum and having leaking. Like that is an increased risk. And multiple pregnancies will increase your risk. But 80% of gymnasts have leaking. 20% of collegiate athletes. These are people who've never had babies. I had leaking when I was 13. I was not even sexually active and I had leaking. So this is not like just some mom issue. That's like such a falsity, and it irritates me being not a mom. It irritates me being like, well, I'm like lumped into this category of like post-trauma, and like birth is trauma. I don't care if it was emotionally traumatic or not. It was traumatic for your body.
Yes, snaps. I say that all the time.
Yes, it's a massive trauma, and I haven't had that trauma, and I already have a dysfunction, right? So what does that make me? And what is that telling people that have never had kids? I have so many patients who have never had kids. And they're even middle-aged women who've never had kids, they have issues too. It's not just a mom issue. This is, frankly, just a pressure management issue, a weakness issue, right? Or a coordination issue, right? Because it could be that you have the strength, but you don't have the timing, or you have the strength, but then you don't have the biomechanics to support that, or you have the strength, but it could be a dietary issue where you're having a lot of bladder irritants in your diet and your bladder is just like, fuck you. Oh, sorry. Can I cuss?
Yes, please.
Should have cleared that one with you. Or it could be, gosh, there's even more issues. Like if you're constipated, that's putting extra pressure on your organs. There's such a tiny space in there. So if you're taking up extra space with your backed up poop, like good luck with your bladder.
Right.
If you're having pelvic pain from endometriosis, if you're having pelvic pain from PCOS or fibroids, like that pain is going to cause a guarding response. And then if your muscles are guarding and spasming, how are they supposed to be functional? How is a tight muscle supposed to do its job? It can't just stay tight all day. Like, can you imagine if your hand was just balled into a fist all day? Can it do its job? No, your pelvic floor doesn't either. So it's such a misconception that also that we talked about that earlier. Like, oh, just do more Kegels. Like, Kegels are not always the answer.
I was going to say, like, let's talk about the falsity of Kegels. I mean, like, for some people.
Right. So if your issue is a true strength deficit, if you're just like, you try to Kegel and you just can't squeeze, like, okay, let's do some Kegels. But like, I'll tell you right now, that's maybe 2% of my patients. I think I've found like 2 people ever that just had a strength issue. And it wasn't a timing issue. It wasn't coordination. It wasn't their biomechanics. They had really great hip stability. They had really great foot stability. They had really great like laugh, cough, sneeze, pressure management. And it was just a strength component. Sure, do your 300 Kegels a day and you'll probably be better in like 6 weeks.
Did you say 300?
That's what OBGYNs are telling people. That I'm literally having, I was being sarcastic and I'm happy you caught that.
Oh, also during my exam, she's like doing an exam, right? Like we're friends. We're like friends at this point. And she's like doing an exam. She's like, do a Kegel. I'm like, okay. And she goes, now imagine yourself closing the curtains. And I was like, what the fuck? That's way different.
Did it work? Did it work? I love it. There's so many different cues I can give people. And it's just like what cue resonates with you and your body mechanics, right? The most used cue that I give people is like a zippering up from like labia up to your belly button. That's the most favorited cue. But the closing the curtains works really well. The clam works really that one always gets a laugh, which is great. What else? The squid, like picking, like, or something like a hand picking up a blueberry or a grape or something, like a squeezing and a lifting. a flower closing flower. I don't know. There's a lot of cues.
So many
I was
analogies.
using a lot of hand gestures for you listening on the podcast, but yeah,
no, it's like
there's a lot of different.
Well, you were saying like sometimes when you like pee, when you sneeze or whatever, it's because you're already you have such a tight pelvic floor that you can't release, like you're not relaxed.
Yeah.
And so something that you told me was like, okay, when you think you're gonna sneeze, like take a big breath, like lower that breath,
right,
and then you have time to rebound, because if you're already so tight, right, you don't have time to rebound, and then you can't clench anymore or whatever.
So that goes back to what we were saying about like, and I wish that people could see the visual, because I have a great visual for this. But if you have a tightened muscle and then you need to give more oomph to it, right? You need to contract it more. A tightened muscle that is already tightened. And so we can't do that. And then it's not going to work well. Like a tightened muscle is not a functional muscle. So so when we say take a deep breath, I literally mean a deep breath, like downwards, not a breath into your chest, like you see everyone go and then sneeze, right? And it's all very chesty. And what happens when we inhale into our chest is that we get this hinging motion from, like, if I inhale upwards, I kind of extend with my spine a little bit. And then when I sneeze, I typically fold forward in my midsection. And that creates a ton of extra downward pressure. And it's going to feel super weird if I ask you, hey, go ahead and inhale, but inhale down into your pelvic floor before you sneeze or laugh or cough. And what you should feel is your belly button going towards your, so your belly button will expand outward with a deep breath. And then exhale, right? My belly button should go towards my spine. And that motion, watching where your belly button is going, is going to be it's not 100%, but it can work to see what your pressure is doing down low, right? So if I'm pushing out with my belly button, there's a pretty strong chance that I'm also pushing out into my pelvic floor. So when people laugh, it should go ha 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 with the belly button going towards your spine. But most of my patients go ha ha ha, and their belly button goes away from their spine, and they're bearing down into their pelvic floor. That is what I'm talking about when we talk about pressure mechanics. So many of my patients have had a prolapse repair surgically, but they never fixed the pressure management. It's just going to put you at risk for a failed surgery, because you're still pushing pressure on the strengthened tissues, which will in time lose their strength.
Well, I just thought it was so interesting too, like the main component of the visit that I did with you, which was our initial consultation, and I have yet to go back because I'm a terrible patient. I still love you. I'm still going to do it. But like,
I know.
Like most of it was like learning how to breathe differently.
Literally.
Like,
yes.
It's so strange.
Because when we talk about pressure management issues like leaking, like prolapse, like hernias, like herniated discs, these are all prolapse or like pressure management issues. The main pressure generator in your body is your diaphragm, right? Like that's how you generate pressure. You inhale, creates more that's how you breathe. You don't suck air in like through your mouth. You inhale, it creates negative pressure. Pressure comes in, right? Because pressure is going to go from an area of high pressure to an area of low pressure. So we create an area of low pressure in our chest cavity. And that is pressure. So breathing is pressure. So if you have a pressure management issue, we have to retrain how you're managing the pressure. And breathing, frankly, it seems so silly, but most people switched at some point in their life to breathing with an incorrect pressure strategy. And you can do it. You can breathe inefficiently, and you can use your little tiny accessory neck muscles to lift your rib cage to create a negative pressure that way. And you're just going to be more prone to neck pain and TMJ issues and suboccipital headaches and a forward head, because you're tightening all these little neck muscles and accessory muscles to help you breathe when you could have just inhaled with your diaphragm, let your belly go. That's the thing. Most people don't want to let their belly go because it's not sexy. It's not cute. And we're trying to hold it in, but like, let your belly go. Let it go.
I have a couple adjacent questions to that
yes,
popped into my head. And I wonder what you're going to say because they're so random. First, I want to underline what you said in the beginning for people this is common, but it's not normal to have these issues. And like, those are such important distinctions. I love that you said that. And we can get more into that. But the random kind of questions that popped into my head are, number one, how do you feel about like breathwork practitioners then? Are you like super triggered sometimes when you're like, like people can do all this breathwork and that's great, but if they're doing it wrong, then it might not be good for their body ultimately? Because that's like such a movement right now.
Okay, so hold on. What is there a specific person who's like I'm a breathwork practitioner?
Lots of people.
And like,
I've literally never heard of it.
They do it in a way like you literally feel high
for anxiety and
Okay,
like, it's like quick,
God, we could talk about
quick breaths like through your like, and then you like do all sorts of weird like
all sorts of stuff.
like
with meditation, breathing, Kundalini is big on breath work and a lot of yoga practices and coming back to the body. I'll let you answer both. I'll let you just have full runway after I ask this other random question. So I actually think I might have helped myself by having my kids live in my ribs and then have this weird rib issue that was caused by my kids living in my ribs and making scar tissue where like my diaphragm basically attaches to the right side of my ribs. And I was complaining about it because once in a while it gets tweaked based on how I move and it feels like my rib is curling into my body and it hurts really bad, almost like a cramp, but I know it's my rib. And I was telling my mom like 3 summers ago and she said, tell your chiropractor. And so now every appointment, he like gets in between my right ribs and my diaphragm and makes me do that breathing to release it, of like making my stomach go up. And that might actually be having even more greater effects. So I wonder too if you see any of that where people, like a lot of women, maybe their issues start somewhere else and then you realize they're breathing wrong. Because maybe I'm noticing now of moving my stomach out because of that weird rib issue. So then they come to you about other things and you're like, oh, it's all connected and maybe your diaphragm's all messed up. That's like not really a question. It's just kind of a comment. You can take it however you want, but like definitely start with the breathwork response.
Okay. Wow. Oh, you guys couldn't see me on audio, but I was nodding like that whole time. So first of all, with breathwork in general, there's so many different breathing strategies, right? And we can totally do the like short chest breathing. It's like, what was the purpose of doing that? Like, what is the intention, right? So my intention when I teach diaphragmatic breathing is what is best for your pelvic floor. Like, I'm always going to look at things through that pelvic floor lens. And what is best for your pelvic floor is breathing downwards into your like 360 diaphragmatic breathing. And I say belly breathing because the alliteration, it like sounds nice and it's easy to say, but like really truly 360 diaphragmatic breathing. You should feel the belly expand, sure, but you should also feel your ribs expand out to the side laterally. You should also feel your low back ribs expand posteriorly away from you. And this is like a breathing drill I do with a lot of patients is I say, okay, great, take a deep breath. And they always go up into their chest. And I'm like, okay, no, I just want you to do a belly breath. So we'll do like one hand on chest, one hand on belly, take a deep breath, only let your belly hand move though. And then they finally, hopefully figure it out right then and there. Some people can't do this and it takes a couple weeks of practice for them. Come back in a few weeks, work on that. And like, we'll just learn how to belly breathe. And because they can't let the tummy go. So eventually we get the belly breath here, inhale. And then I say, great, put your hands on the outsides of your ribs, both hands on the outside of the ribs. And I want you to expand laterally into your ribs out to the side. And you see how my breath changed, right? And both are correct. Like both are great breathing. There's just all these different breathing styles. And then I say, great, put both your hands on your low back. And you should take a deep breath into your hands back there. You should feel your ribs expand backwards a little bit. And yes, based on how we're all slumped in our chairs sitting, it might be more difficult to feel that one. And the low back expansion is probably the most difficult in general. You can also put your hand down at your perineum and yes, in between your like like crotch, right? Like we could put our hand down there and inhale down into your hand. And you should feel your pelvic floor, your perineum kind of descend downwards into your hand a little bit. It's very subtle. On your inhale should go down into your hand, and on the exhale it should lift up a little bit. And thus just like demonstrating like we can send our air to different places. There's so many, like you have a whole lung, like there's lobes of lungs. There's so many. And based on which part of your body you maintain more rigid, you're going to send the pressure elsewhere. So I don't know if you noticed, if I want to do a chest breath, I have to hold my belly more rigid in order to let the air only go up here, up to my chest. So based on what we let go and what we maintain more rigid, we can send air different places. Does that make sense? Okay. So with the breathwork practitioners, I'm hoping that they do teach different styles of breathing. The reason that breathing makes us feel calmer, there's a few reasons, and we can get real nerdy here. You've got cranial nerves that come off your brain, right? And most nerves come off your spinal cord, but you've got like 12 nerves that come straight directly off your brain. And one of those nerves we're going to talk about is the cranial nerve 10, the vagus nerve. It's VAGUS, not like Vegas, but like Vegas.
Very trendy on TikTok.
Yes, I know. We're all about the vagus nerve activation these days, but so am I. So with your pelvic floor, so your vagus nerve, first of all, is in control of that parasympathetic rest and digest, right? It goes, and strangely, most cranial nerves stay up in your cranium, your head, right? And they control like facial movements and swallowing and your eye movements. But no, the vagus nerve goes all the way down. It passes through your diaphragm and goes all the way down and innervates and branches and it innervates your organs. So it's literally in charge of rest and digest. And since it penetrates through your diaphragm, if you're not taking a deep downwards diaphragmatic breath, you're not stroking that vagus nerve. So if we are taking deep breaths, it is literally activating your vagus nerve and creating calm. And it's direct to brain. It's physiologic. You can't take deep breaths and not feel calmer. Like it's just physiologically not possible. So yes, I love that people are practicing breath work. I have no idea what these people teach, but I am hoping that they're teaching diaphragmatic breathing and how to expand that. I'm very curious if the short breaths are creating like an increase in carbon dioxide in the system, and that's what's creating the high. But I'm hoping that it's the diaphragmatic parasympathetic activation. Who knows?
You know what else Louise Hay told me in this like YouTube compilation? And for anybody who doesn't know and who isn't obsessed with Louise Hay like I am, she's the founder of Hay House, and she wrote like You Can Heal Your Life and is super famous for any book that you've probably read about spirituality. It might have been published by Hay House. That's their whole thing. And she said in this one of these compilations that always sticks out to me, women were taught not to breathe, kind of like a worthiness thing all along of like, you know, women aren't supposed to take up space. And so we inherently, and I don't know if this is true or not, but I believe her, is we breathe more shallowly than men do in general. So teaching ourselves to take time and space to actually breathe fully is a big deal for women. And I would imagine that, you know, we have a lot of factors working against us, least of which is some of our conditioning bringing us into an office like yours of like, I've been breathing shallowly my whole life, and that hasn't done me any favors when it comes to like building and pushing out kids, and even before that, like in how my body is managing like the pressure of everything. So
right. I'm not familiar with her. I probably nerd out on more like pelvic information when I'm choosing what to listen to and everything, but it's very common to not be breathing efficiently, right? And it's not that you're doing it wrong. It's just like when we look at it through a pelvic floor lens, then we probably need a little bit more diaphragm excursion. If we are like running from a bear, then sure, get all those accessory muscles on board in your neck. Like, let's get everything on board and really get the most out of each and every breath. But if we're looking at it through the pelvic floor lens, the focus should be on that deep inhale downwards and outwards. I hope that answered your question.
It totally does.
Yeah.
I also wanted to the hip part of this. Like, it's not just...
Let's talk hip.
Yeah, because during the consult with you, you're like, okay, I want you to stand on one leg. And I'm like, what the hell is happening right now? And you're like, okay, like squat low. And you're like, see, you're all wobbly. Like, and like, it's crazy. Like, there's so many muscles there that I'm like, I don't even know what that is. Like, I didn't know it hurt until you touched it. And I was like, ow, ow, ow. Like, so weird.
Yeah. So okay, there's so much that I want to look at in an hour-long eval. I just frankly could do a 2-hour-long eval and still be finding things with people, right? So I try to really quickly screen for everything. So one of the things that I found, rather than doing single muscle testing on every single muscle, I can just do a quick global screen of like, great, can you pistol squat? Like, can you single leg squat? And so I have you stand on one leg. If you can't even stand on one leg, I'm not going to ask you to squat. But I typically ask for a pistol squat because I want to see if there's instability up the chain, right? And let's talk about why that matters. So either your foot or your hip, typically not your knee, because your knee is a pretty like dumb hinge joint that's kind of pinned in between two complex rotational joints. But you have a rotator cuff muscle group essentially, and it's not the rotator cuff of the shoulder, but you have a small rotator cuff group of your hip. And all these little tiny muscles need to activate, but they're just little tiny activators. They're not your main stabilizers. Your main stabilizers of your hip are going to be your glute med, your glute max, your adductors, your hamstrings. Like those stabilize.
Glute med? I love that. Sorry, keep going.
Gluteus medius, glute med, like MED.
Oh, I was like, can I use that in an upcoming article? Glute meat.
Yeah, the glute meat. I love it. The glute muscles, those main big giant muscles that are crossing over the hip joint from pelvis to femur, those are going to help stabilize the hip the most. But if those aren't activating in the right pattern and in the right way, then the little teeny tiny accessory muscles that are closer to the joint, and there's a bunch of them. I could show you a picture, but we're audio. But there's a bunch of little teeny tiny hip muscles that attach from the femur to the pelvis, just like little tiny ones. And those are just accessory muscles. And so one of those in particular is called the obturator internus. It is a pelvic floor muscle. It goes into your pelvic floor and it goes out and it attaches onto your femur. And if that muscle is irritated internally when I touch it, or externally, you can palpate it externally. If I touch that muscle and it's mad, I will die on a hill and fight anyone. And I will say that you have a biomechanical component to your pelvic floor issue because it's a hip muscle. It's a hip stabilizer. Why would a hip stabilizer be irritated if all the other muscles in the hip were doing their jobs adequately? Like I'm very adamant about that. So why would the obturator internus be flaring up? Well, is it a hip stability issue or is it coming from your foot? There's so many patients that I've found with like, oh, well, yeah, I had this bunionectomy, or I had this like foot fusion, or I have this like, oh, I just pronate my feet. I've got little flat feet. It's just a thing. I just wear orthotics. And I'm like, well, we've got to address your foot problem because the shock absorption coming up the chain has to go through your pelvis. And if it's not being shock absorbed properly through your foot, through your hip, it's going to be absorbed in your pelvis or into your low back and your spine.
Okay, I just have to say, like, this is so informational. And also, I love how, like, aggro you're getting about this. Like, she's so mad, you guys. Like, fuck you, hip muscles, do your job. Like,
yeah. And using words that I understand in the middle of words that I don't to, like, make it super relatable. Yeah. No, this is so I'm following. I love it.
Part of why I'm so mad is because I'm a failed patient. I was a patient. This was a decade ago. So, like, bless our field heart, we've come a long way in the past decade. We had this pendulum swing that was all about Kegels for a while, right? And it was like, oh my God, we have to do Kegels. And we would put these little biofeedback sensors all over people's butt. And we would be like, okay. And you had like a little screen and you'd look at the little screen and it would show this little like bar line when you Kegeled, and it would be like, it would increase and be like, look, you're Kegeling. And then like you would relax and the bar would go away. And it was like a little video game with like sensors
They
attached
still have
to your
that.
butt.
Well, they have the internal one now.
Oh, I know. So here's the thing. For the volume of time it takes for me to set up the biofeedback sensors, do the right placement, turn on the machine, tell you how to tell you about the machine and how to use it. And then for me to have you do a Kegel and see the little bar and then work on all that, and the money expense of, it's not like I can reuse those sensors on somebody else. It's not like I'm going to like put them in a little Ziploc bag, label them with your name and keep them for you in my file cabinet. Like just the cost and the expense and the time expense of doing this Kegel exercise horizontally on your back. Was that really the best use of our time together? No. I came into you with complaints of leaking with running. There's at least 12 steps for me to get off the table and single leg stance movement with pressure management. And why do we think that a Kegel is going to fix that? Like we talked about earlier. So I get fired up about biofeedback because that was like the focus for all of my visits as a patient. But this was also in 2013. So 2013, 2014. So it's a long time ago. So I get very pissed about like patients not being treated functionally. That never helped me stop leaking with running. It's such bullshit. I get pissed.
That leads me into though, like, how did you get here? Like, was that like, wow, I'm so angry, I want to fix this?
And like, what did you do before? Because we are
I was
almost...
like, this is such a stupid thing. I was like, this is such a stupid profession. Why would anyone do this? And
it's life-changing.
Well, when it works, sure. But like, it didn't work for me. But that was because we weren't focused on how I was running and my single leg stability. We weren't focused on my core stability. All they were doing was telling me I was breathing wrong and to do Kegels. That's like half of it, kind of, I guess. So at the time, I was a physical therapy assistant. I was in the military.
You were in the military?
And yeah.
What branch?
I
and
was.
like, where did you go?
Oh God. So I was in the Navy. The first 4 years I was a search and rescue swimmer on helicopters. And then I started having really bad migraines and lost my flight status because you can't fly when you go blind intermittently. So I lost my flight status and I was kind of okay with it. And so I switched and I was able to pick up medic. So I went through EMT school and then I was able to go and pick up it was very rare that I was able to do this, by the way, but I was able to pick up the physical therapy assistant school right after the EMT school. So I went through EMT school, then physical therapy assistant school in the Navy. So they're abbreviated and they're fast paced. And so then I was a physical therapy assistant in the Navy. So then I was working and that's when I started having a labral issue. So I had a labral tear in my hip and the walking got really painful. I really couldn't run without any leaking at that point. And so that's when they sent me to the pelvic floor PT and it just wasn't working for me. Like it was just like this stupid biofeedback thing, being told I was breathing wrong. And I was just very frustrated.
Can we also talk about when you got sent to the pelvic floor PT? Did your insurance cover it?
I was in the military. Okay. So yeah.
Do most insurances cover it? Absolutely not.
So the shitty thing is, here's the thing. Insurance has cut our reimbursement rates for the past like few years in a row. And since they cut our reimbursement rates and also they incentivize us to do certain things with you by paying us very different amounts of money based on our billing codes. So I am paid way more money to do neuromuscular re-education than I am paid to do manual therapy. But doesn't internal work fall under manual therapy? Like, what if I think you really need internal work? Then I'm either incentivized monetarily to not do that with you or to commit billing fraud or to do it, but then I lose money.
I kind of didn't mean just for you, but that's fucked up. I just meant like in general.
That is insurance in general.
Yeah.
So, okay, so I'm getting to it. So because of that, most specialists stop taking insurance because frankly, I was incentivized to see 2 patients per hour, which means you're either being seen by me for 30 minutes and then by an assistant or an aide for 30 minutes. which that's a high school student if they're an aide, typically a high school, maybe college, but they don't have any training apart from on the job training of like, here's how to do a proper squat. Here's the compensations to look for. But like, why are you having her do the squat? What happens if she gets the hip pinching during the squat? You don't know how to correct that. You don't know the why. You're frankly not allowed to touch her. So you're either seeing me for 30 minutes and aide for 30 minutes, or you're seeing me for just 45. And like with all the education I do and the to really truly look at someone in a functional, holistic way, I don't believe that 45 minutes is enough. An hour seems tight sometimes, frankly, when we're looking at everything from diet to spine to foot, like to pelvis, to hormones, to vulvar tissue, like all of that is just, it's a lot. So I stopped taking insurance because of that. So because of that, it's tough to find a specialist who is in an insurance network. Now you will, but they're going to have a wait list. So I have a pelvic floor PT friend. She's got 125 people on her wait list, and that is standard for her. But so by the time you get to a pelvic floor specialist, you are a chronic pain patient because you just frankly aren't going to get there within 3 months. And that's if you knew that we even existed.
My face is like very frowny. If you like, very frowny.
Because by the time you realize something's wrong and you decide to bring it up to your MD, if you are dismissed, which you are often, you're not going to bring it up again until you talk to a friend a few years later and you bring up this awkward conversation and you're like, oh, what do you mean? You don't have to push up pressure on your perineum in order to poop? That's not normal. Like, you don't have to insert a finger in your vagina to push your rectum back in place in order to poop. That's not a normal thing. Oh, okay. Maybe I should go see someone about that. Or, oh, I shouldn't be having pain with sex. Oh, that's not normal. Oh, I shouldn't be having, this feeling of something falling out. That's not normal. Oh, oops. I should probably go see. I remember asking someone and they dismissed me. Maybe I should ask again. And then you go ask again. And then they refer you to a urogynecologist who only wants to do surgery or give you a medication or give you a bladder installation or some procedure, rather than just like, we have direct access. You could call me. I could see you next week. But you have to know that I exist.
Rachel exists. Everyone, we're gonna talk about like where to find you, but also I stole your story. So like you went to the PT. You went to the pelvic floor PT. You were referred. What happened next?
Yeah. I didn't get better, and it took a really long time to like self-diagnose and self-figure out. And then after I left the military, I got into the doctorate program, and I did not want to do pelvic floor, but I was assigned to the fecal incontinence research group. I was kind of already like in that world, and I had already known as a patient what we did in that world. And I still was like, hard pass. Anal manometry is not my jam. I don't love this.
I'm learning so many words. Anal manometry.
Oh yeah. It's a thing. And it's very needed. And like, it's important. Like, people need to not poop themselves. It's really important. And it was just not my jam. And I did not love it. And then there was like this moment where I was sitting around a table with a bunch of older, like middle-aged mom friends. And they all laughed, and someone said, don't make me laugh. You're going to make me pee. And everyone laughed. And I was like, hey, you guys, that's not like normal, right? And they all looked at me, rolled their eyes. You're going to be just like us when you have kids. You just wait. This is you too. And one of them started talking about how, oh, well, I just fold this origami piece and I just shove it around my urethra and like use the toilet paper and just shove it in there. And like, it solved my problem. So you guys should try this. And I was just like, what are you saying right now? And I just like, it was that moment where I was like, oh no, like I have to do this work. Like this, it was just this moment of like, if not me, then who? Like, I'm very comfortable talking about poop and pee and like all the things.
All of us.
And I was like, yeah, I'm very comfortable talking about all the intimate, like, oh, what sex position were you in when it hurt? Oh my gosh, say more. Was it deep? Was it this? Was it this angle? What position were you trying? Like, so there was just this moment of like, oh shit, this has to be me. I have to do this work. And like from then on, it was just full steam ahead. Like, this is it. This is what I'm doing.
Can we make a shirt that say like, no urethra origami? Like,
right?
That's insane.
I know one kind of We could talk about this forever. I have
We
one
could.
kind of loaded question.
Let's go.
Question is, so as you're talking, what I'm hearing and what I'm thinking from my own experiences with people in my life, and I'm trying to be better about this generally because my mom and my grandpa and I were all going to live until at least 110 because we are preventative. Whereas I imagine a lot of people are coming, like I could just come in and be like, show me what's wrong with me. I think like sometimes I have to pee a little more urgently than I used to, but overall, aside from my diaphragm thing, like I'm sure you would find things wrong with me, and I would be that person that's like super curious about myself and my body, and I would want to come in and see you just to get ahead of things to see what's wrong with me. Whereas I imagine that a lot of people come into you with acute things going on, like it's become urgent and they need to see you or they realize that you exist. Is it your part of your mission to get people in a more preventative place where like you're added on to like just what people do for themselves? Or is it like fine with you that it's acute? Like, would you like it to be less urgent for them where they're like, let's just have a check-in every couple of years, or like that's part of physicals, or men when they get their scrotum tickled or whatever they do during their thing? Like, should people be coming to you as part of their routine, like in your perfect world?
She doesn't tickle them. I just want PSA.
Whatever, they cough and
Rachel,
head to the
I
side.
thought you meant like Rachel's services. She's not a scrotum tickler.
Oh, and
no, but I'm talking about physicals that men get.
One of my pet peeves is when people ask us to do vaginal massage or like pelvic floor massage, and I'm like, oh, don't ever say those words again, please. Like, first of all, no. Second of all, I don't perform those services. Like, we may use like certain massage techniques.
No happy
at
endings.
Your pelvic floor,
Got it.
but like, no, please no. There was a referral once from an MD that said, patient referral for vaginal massage, and we were like, we got to call this guy and like educate this MD who's probably telling these patients, I'm going to refer you for vaginal massage. What?
Gross.
No, sir. No. Like, it's so much more than vaginal massage. Okay, guys. No. So, first of all, in other first world countries like France, pelvic floor physical therapists are at your like 6-week checkup. Like literally they're part of your postpartum care as a regular basis that is covered by insurance. The problem in America is that our insurance model is for profit. And as long as our insurance model is for profit, you, the patient, are not the winner. It is always the shareholders that will be the winner. And how they make money is not by giving you care. So I do have a lot of patients that pay out of pocket. But I have a lot of patients who have HSA cards or FSA cards or have reimbursement for out-of-network benefit stuff from their insurance, and I can give them super bills and they can get reimbursed from their insurance. To answer your question, I wish it was just frankly more talked about, more known, and that we didn't wait decades to fix these issues, and that we did preventive care would be great. But part of that preventive care starts with educating our MDs better and educating our MDs on when to refer. So I've had a few patients tell me, oh, well, my MD told me this, but I know it's not right, so I came to see you anyway. And I'm like, that is horrible that they get like a few months of musculoskeletal knowledge and they don't refer on when it's not in their specialty. So that is a huge, it's an educational breakdown that's happened, that they're not understanding that we have literal 3.5, 4 years of musculoskeletal training. And, we also learn some pharmaceutical. So obviously I cannot prescribe pharmaceuticals. I'm going to refer if I think there's an estrogen issue and they need to talk to you about their medication management. And that's not me. So when it's a musculoskeletal thing, they should be referring to us and not just telling patients to have a glass of wine before sex. Cause you just need to loosen up. Or you just need to do 300 Kegels. Like, who are you to prescribe Kegels? Like, who are you? Like, I get pissed. I get pissed about it. So yes, to answer your question, I wish it was more talked about, and like the normalcy was like, hey, it is not normal to have pain with your period. It's not normal to have pain with pregnancy. It's not normal to have leaking with, jumping. And it's not normal to leak when you laugh, cough, sneeze. Like, that is not normal. you should get help. And you don't have to wait for a decade until you're wearing Depends, because by that time, I now have a decade's worth of compensations to untangle. And you want me to fix you in 3 months? It's not going to happen.
Yeah, it's just, I think you're going to help so many women because, you know, we don't know how big our audience is, but anything helps where they're learning and then they're going to go tell their friends because we are the best communicators on the planet. And we're going to go be like, did you know that you're not supposed to pee yourself and this actually isn't funny? Kind of like I went on this little tirade about like the wine mom thing. Like, that's not cool. We shouldn't be like thinking about curing our lives with wine. That's actually kind of a problem. Just like peeing on the trampoline with your kids and laughing it off, that's also a problem that we're just making okay when it's not actually okay. And there are people out there who can help you.
Yeah, absolutely. And we could seriously sit here and talk forever about all the misconceptions and all the like jokes that are made. And it's like, sure, you can make that joke, but are you making the other people think that that's normal because you're joking about it? Because that's not being a helpful friend, right? Like, if you're trying to cope with something that you're uncomfortable with, trying to make light of it is a natural response. But if you're making light of it and that's telling other people that that's a normal thing, then that's not healthy. That's not being a good friend, you know?
We have some rapid fires for you that I'm really intrigued to hear your answers to. What are you proudest of in your business right now?
So right now, so I started the practice about almost a year ago, and I have already hired an admin. I have already hired a part-time PT. So she's starting next month. So within a year, the fact that I'm already hiring is like scary and terrifying and, you know, exciting and shocking all at once. And then we're also moving into a commercial space in Lake Stevens, which is, you know, moving out of my little private treatment area in my house is like a big step for us guys. And, you know, it's going to allow us the opportunity to like A, have a waiting room, which is really nice. And B, have like more space to move and have like kind of an event space also eventually. So it's big steps are being made. So I think that's just like how do I say it? Like the speed with which my business has grown is just a testament to how much this is needed.
Right. Yeah. Snaps to that. Yeah. Tell us about a book you read or podcast you listened to recently that changed the way you're thinking about your life or your business.
Oh gosh. I was reading this book this is the most recent one I was reading was like, was it called The 7 Types of Working Genius? It was just talking about like how if you're really good at marketing and in your business and you're trying to work as a team with other people on the team, and if someone else hates marketing, why would you put them in that role? Why can't, like, just because that's their job description, like, why not put them in a role that they're really good at instead of making them miserable just to fulfill the role? So it's more like, it's about looking at like, and even in your personal life with your partner, being like, okay, great, you hate doing the dishes. I don't mind doing the dishes, but I hate taking out the garbage. Can I just do the, you know, like having those, like, why force it just to say that you're helping or just to say that you're a good partner? Why can't a good partner be the one that's like happy doing that job? Like, if I'm really good at planning, and like, yeah, sure, it feels nice sometimes if he plans stuff for me, but like, if I'm really good at planning, why would I force him to plan the family vacation when I know that I'm good at it and I enjoy it? So why force him to do it just to say he did it, right? Like, it's more like putting people in the roles that they're really good at doing and they enjoy doing so that they don't resent it later.
Yep.
Makes sense.
We're both all about that.
Yeah.
What would your last meal be?
Good question. I'm a big seafood person, so probably like some like bomb scallop dish, something.
I love scallops.
lobster scallops, so probably good. Yeah.
I had a weird experience with a scallop and like 10 years ago, and now I'm just getting back on the train.
I love
There's this sushi restaurant in Ballard where I think we had so we got like the chef sampler, and my husband and I were very open food wise. And so I don't like the one where I think it's sashimi, where it's just attached to the rice with wasabi, because I don't like wasabi. So I took the whole bite in my mouth, and I was tasting the cold scallop, which was humongous, attached to the wasabi, attached to the rice, and my eyes were watering so much I wanted to spit it out, and I had already committed. So it just all happened. My husband was staring at me you can spit it out. It was just this whole thing. But cooked scallops I can do now, but not so much in the sushi format. It was so hard to swallow that moment, because I just wanted to get it over with. I'm sure a lot of women would say it was so hard to swallow in that moment about various things. And yeah, the scallop, I think I'm finally past it, but I would never have it probably cold again. Cooked scallops for me.
I like the cooked scallops, but I'll have them on sushi rolls when they're cold. And there's the best sushi rolls when they have the salmon and the scallops. And yes,
just the humongous scallop with the wasabi. Oh my gosh, it's traumatizing.
Sounds like heaven.
Yes, next time we'll give it to you.
I'll take it. I'll take it.
Put it to the side for Rachel. What is the best business purchase you've made in the last 6 months under $100?
Well, obviously I do a lot of exercises. So there's this over the door strap thing that just is an anchor for clipping on different resistance bands. And I try not to use stuff in my practice that like a Pilates reformer. Sure, that's great, but it's not like my patients have a Pilates reformer at home. So I try not to use stuff that they can't replicate at home. So just something as simple as most patients have some sort of stretchy band at home that they can use. So I used this over the door strap that was $30 on Amazon a lot. Not because it's my favorite thing in the world, but because that is something that I can give you that gives you something effective to work on at home when you're not with me.
Nice. And what is lighting you up lately?
The glimmer of hope that is the sunshine that's been... Just a little bit of sun has been really nice.
Big facts, because we're all vitamin D deficient.
I know.
Which is a whole other layer to everything.
I know. Yeah, because coming from California, this has been a little bit of a rough winter for me. So this is it's been fun. It's been good. But the couple days where there was sun, I was oh, that's what I've been missing.
Mm-hmm. It totally changes your attitude and
yeah.
Well, Rachel, we're so excited to have you. Where can everybody find you?
So and you wanted me to talk about okay, guys, have to check me out on Instagram, because I frequently wrap in a vulva costume on.
Wait, Emilie, is that your coat? Did you get it from Rachel?
No, it is not the coat. She made a beautiful, different shades of pink. It's...
I wish I made that. Girl, I ordered that on Amazon.
I thought you made it. I was so impressed.
Could have been my favorite business. No, because I looked at making my own, because on Amazon it was $70, but to buy 3 rolls of felt in different colors was gonna be $60, and I was okay,
plus your time.
Buy the vulva costume. Yeah. I was I'll just buy the vulva costume. It's whatever. It could have been cuter. The labia are really flappy on it. I wish it wasn't quite so.
Why
flappy.
Is that bad?
Beef curtains.
No, the top labia, where the clitoris would be, is ultra flappy, and I wish it wasn't quite as flappy, but I could hot glue it. But anyways, you should find me on Instagram.
Do not hot glue your actual labia. Pro tip.
Disclaimer. My Instagram is, hold on, I should know this, but I don't. That's embarrassing. My Instagram is @empowered_physical therapy. You can find me on my website, empowered-physicaltherapy.com. Those are probably the easiest places to find me, but you could find me on Facebook. I think it's empowered-physical therapy on Facebook. Find me, watch me rap. It's fine.
Can I tell you a quick clitoral story?
Yes, I love clitoral
as we
stories.
wrap up. So
always.
Yes. One of the things that I really appreciated about my time in the Greek system in college is that my ex-boyfriend was in a fraternity that was known to be very douchey. And it was a correct assumption. And one time when I walked over to visit him, they had one of their educational evenings, and each time it's set up for like a member to present. And they were presenting on cunnilingus and how to like please a woman. And I cannot tell you how impressed I was with them.
I love
to
that.
like have this group of like, I'm talking, it was the time like right past the double Abercrombie popped collars.
Yeah.
He included double like fake diamond stud earrings, frosted tips, situation, 80 of them in a room learning about cunnilingus.
From a man, though? I don't think I could teach. Yeah, I get it.
Yeah, I would rather learn from a man. If he's somebody, learn on the job. If he has been trained in it, and I'm like, this is not really relevant to Rachel's world, but the fact that like these men are comfortable. And I find a lot of times, like, men are much more comfortable talking about these things than women are because we're so, like, conditioned out of it. Like, we have to be good or whatever. But the fact, it helps that these men were out here, like, talking about how to please women. And, like, I would think that all these boys, I've watched them grow up, they would be telling their wives, this is not normal. You need to go see someone like Rachel. Because they're so comfortable. This is a little bit of a stretch. But I will... any opportunity I have to tell that story, I'm like, these men are like very impressive in the way that they think about how like that it's just not weird. None of these parts are weird. There's nothing to be embarrassed about. And they're setting each other up for success for like, sexual revolution.
Well, and that's the thing. Most women are like, postpartum in particular, I found they're like, oh, I've never looked. I don't know. Some shit happened down there. And I don't know. It looks different. I don't want to look at it. And I'm like, does your spouse think it looks different? And they're like, no, they never said anything. And I'm like, because it probably doesn't look that different to anyone but you. Like I've seen a lot of vulva and none of them, I wouldn't be like looking at one and be like, that one's postpartum. Like that one I could definitely tell. No, not like, you guys are so critical on yourselves, and your vulva are all supposed to be asymmetrical. They're all supposed to look different. It's going to look a little different postpartum, and I promise you, the only one who cares.
Big facts.
Yeah.
That's a great place to end it.
I'm gonna link. We'll link to the vulva costume.
Go look at your vulva.
Look at your vulva.
Go look at your vulva.
Look at your vulva.
Yeah. Get familiar with it. Love it. Rap at it.
Yeah,
it's like a plant. Sing to it.
That's a great.
Rap at your vulva,
and
guys.
you like write your raps.
No,
with AI, right?
Yeah, I used AI. AI wrote the bass, but it kept talking about Kegels in it because the stupid internet. So I had to rewrite some parts, but yeah, the base of it was written with AI.
AI wrote your vulva rap.
It sure did.
Wow. That like makes it even better. Like that is a great, as somebody who's like kind of against AI for writing, that is a great use case because it's so robotic and weird that I would appreciate it. Like,
I think you're really gonna like my vulva rap.
I can't wait.
And, okay, let me tell you, the people that are dancing in the background, they were all other pelvic floor physical therapists. I was at like a business retreat with them. Amazing. And I was like, hey guys, I'm gonna need you to be in my video.
We're gonna do a flash mob.
It was great. It was great. It was wonderful.
I love it.
That is like normalized vulval rectal education and
right? Yeah,
comfort.
I'm here for you.
Viva la vulva.
Ah, that's a great business name. Why didn't I think of that?
You can change it. It's not too late.
Next time. TM by Emilie.
TM.
Okay, I don't know why I was doing this. I was like, bye, see you later. But
no, you're like basically doing the shocker. Emily's trying to do the shocker on the video. Good thing nobody can see it.
Bye, see ya. It was great to have you, Rachel. Thank you for being here.
Thank you for inviting me on, guys. And, if there's anything wrong with your genitourinary system, come see me.
Yes, do it.
Or if you're just like super curious and preventative, go see Rachel anyway. And do
the urinary urgency stuff that you mentioned, like normal voiding is like 8 to 10 times a day. And people are like, oh, I just have a small bladder. I'm like, you don't. You anatomically do not.
I think you told me that my bladder is like a little bitch ass chihuahua is the analogy you used.
I did. I told
no,
you.
you cannot.
You got to be the master. You can't give your dog a cookie if it's begging at the dinner table for the food, right? Like, you don't give the dog the food right then. You got to tell your bitchy Chihuahua bladder to like sit the fuck down, go lay down. And then once it goes and lays down, then you can reward it with the bathroom trip, right? You can't give the bladder the cookie at the top of the urge. No.
I'm so glad that that's how I treat mine.
But you also can't like overhold, right? Like, you have to go.
Mm-hmm.
You can't not go. You still have to go. So there's a whole thing.
Oh my
Next
gosh.
time.
Yeah, we'll have to do a
bladder.
part 2.
Yeah. All right, guys.
Well, thank you.
Thank you,
Everyone,
guys.
we will see you on our next episode.
Bye.
Bye.